There is one organ which causes high blood pressure, and it's not what you think. And there are specific exercises you can use to target and fix your blood pressure easily. No diet, lifestyle changes, or medication required. Check the link in the description below, but for now, today's question.
The question, what is the one thing I should know about taking blood pressure medication? Answer by Liang Haisi. To start with, see one trusted and competent doc if you needed more than 3 drugs to control it, so-called treatment-resistant hypertension, like I have. You need specialist care. I was my own specialist, discussing the matter with our GP, a trusted and highly regarded doc about 10 years my junior. In spite of all modern meds available all having their rather specific side effects, impaired kidney function due to ACE inhibitor like lisinopril is rather rare, usually caused by too high a dose relative to kidney function and dehydration. See https://online library. Wiley.com/ It mostly will spontaneously recover over a few weeks' time. That's why kidney function needs to be monitored before and after starting treatment. If kidney function was okay and there was no history of gout, we should start with the very familiar, old, cheap and very effective super long-acting diuretic, water pill, chlorthalidone, low dose 12.5 mg a day. See the very large, 33,357 participants, 2002 HAT study. Major outcomes in high-risk hypertensive patients randomized to angiotensin-converting enzyme inhibitor or calcium channel blocker versus diuretic, a summary of the results of which can be found on the OHAT. Thiazide diuretics as first-line antihypertensive therapy, Classics series, 2-minute medicine, showing that chlorthalidone, not prescribed so much anymore since being old and cheap means no farm reps were selling it to the docs, was as good as a modern ACE inhibitor lisinopril and the modern calcium channel blocker amlodipine. The results still hold true after a long follow-up reported in 2013. http://hyper. AHA Journals. org/con. Beta-blocking agents, never to be prescribed in monotherapy, but helpful in people having heart failure, angina pectoris, too fast a heart rate and anxiety issues, so should be reserved for this group of patients, can cause fatigue, cold fingers and toes and erectile dysfunction in males. ACE inhibitors I already mentioned. Far more important is the fact that around 15% of the users develop an intractable cough, so the med should be stopped. It is a very useful med for heart failure. Angiotensin receptor blockers are closely related to RAHAS, they cause a lot less cough. Calcium channel blockers can cause leg edema and rarely flushing. So if chlorthalidone alone wasn't enough, step by step every 2 to 3 weeks either the dose should be raised, or better a second and if needed third med added, the choice influenced by my observations above. If no other diseases were present I would escalate along this line: chlorthalidone 12.5 mg/day greater than add ACE inhibitor and monitor kidney function greater than add calcium channel blocker greater than double the dose of chlorthalidone to 25 mg/day. Then there is when to take the meds, to inhibit the early morning blood pressure peak, correlated with a peak in the incidence of myocardial infarction and stroke. I tell my patients to take their meds before bedtime, only for chlorthalidone this doesn't matter, if being active for around 36 hours. This does lower the morning blood pressure peak, reducing cardiovascular events, without side effects. See https://www.ncd, NLM, NIH. gov/PMC. Several studies have found that bedtime dosing of antihypertensives reduces sleep blood pressure and improves the dipping pattern in non-dippers. One small study and 2 sub-studies in diabetes and chronic kidney disease suggest that bedtime dosing of 1 or more antihypertensives significantly reduced CV events. A Cochrane review of 5 studies found no difference in adverse events between morning and evening dosing. Answer by Bruce McFarland. It must be used continuously. What follows is a list of reasons people use as excuses after I see them for treatment for high blood pressure, even though they had already been prescribed medicine. I thought treatment was over when I finished the bottle. I forget to take it. I didn't like being on medicine. I'll get better on my own. It made me fill in the blank. Gain weight, feel weak, have a headache, nauseated, cough, go to the restroom too frequently, etc. ad infinitum. It is too expensive. Deciding to change or stop dosing your blood pressure medicine is always worth a discussion with a doctor. Each of these excuses can be dealt with before a problem occurs that is irreversible. Certainly, a switch to a different medicine is preferable to a stroke, heart attack or other organ damage. Too many patients think they are qualified to make medication choices, but do not recognize the consequences of high blood pressure. In my experience, the people who quit taking their blood pressure treatment are forever making up justifications for doing it. Because I am used to hearing the excuses, I try to prevent the improper use beforehand by reminding them of what to expect. A set of instructions, including, "Don't stop taking your medicine without discussing it with me first," is always the doctor's responsibility, both ethically and legally. I'm not saying it has to be taken for the rest of your life. Once a commitment to medication is agreed upon, it is meant to do the job together with lifestyle changes to lower blood pressure. So, continuing to lose weight, avoid salt, exercise, quit smoking and moderate alcohol use can be the path to taking away prescription blood pressure treatments, in partnership with the advice of the doctor. The good news is, people following lifestyle recommendations can live between 12 to 14 years longer than the average lifespan. Circulation, April 30, 2018. If it is in my power, I will avoid hearing the excuse, "I didn't know." Answer by Robertson Shamer. In my opinion, the first thing to understand about BP medicine would be the importance of things you can do, should do other than drugs. Non-pharmacologic management. While not likely to lower the BP all the way to target normal, lifestyle changes will likely reduce the number of medications or the dosage of medications required. Cut out cigarette or tobacco use. Reduction of alcohol, I have found, can by itself return BP to normal in many people. Reduce weight, especially around the middle. Start exercising, gradually. Eat more fruits and vegetables and less processed foods. Avoid unnecessary salt. Strict salt or sodium control is no longer thought to be necessary. In some cases, treat your sleep apnea. Do you snore? Do you awaken out of breath? The BP is not the thing that matters most, it's the part about not dying or having a stroke before your time that matters most. Lifestyle improvement goes way beyond what pills can offer, even though pills are necessary in most cases. So as you start medication, don't focus on the pills. Take them, but as necessary as they may be, they are not the most valuable thing you can do for yourself. Also, start low and go slow. Make sure your doctor checks your blood for kidney function and diabetes. Know that there are different classes of medication. If the first med does not get you to goal, know that adding medication from another class works better than switching from a drug in one class to another. But if you have a side effect, then switching from one drug in one class to another makes sense. Fixed combination drugs are to be avoided due to inflexibility and cost. Patients do much better taking BP medication at night, and with all the stuff your doctor is doing for you as a new BP patient, that pearl gets forgotten. Use one of those plastic pill minders. You don't have to be forgetful to forget your daily medication. Does this help?